the registration link pop the registration link into the chat. We are, again, going to have some incredible presenters and guests. This is going to be Peter Emby joining us from Vanderbilt, as well as Karen Deep Singh joining us from UCSD to comment on a trial that is happening related to venous thromboembolism, as well as algorithm of vigilance. Hey, Peter, good to see you. All right. Well, with that, I'm Vinny Liu. I am the overall PI for the AIM High project. And as G mentioned, we have had the pleasure of soliciting and then selecting 5 projects, which are real-world implementation of AI in trials for the purposes of diagnostic decision-making. And we were particularly delighted to support the project we're going to hear about today. So joining us is Dr. Siva Bhavani, who's a pulmonary critical care physician scientist dedicated to applying machine learning to routine bedside measurements to identify precision approaches to sepsis. Much of this work started with research he's done related to body temperature that has become an innovative framework adopted by many scientists. That temperature trajectory work led to an NIH Career Development Award in which he discovered the vital trajectory subphenotypes as a tool to guide precision medicine approaches in sepsis. Dr. Bhavani is collaborating with the Emory Digital Office to integrate the vital trajectory algorithm into the electronic health record in preparation for the Precise trial, which we'll be hearing about. And then once Dr. Bhavani is done, we're joined by Derek Angus, who's a world-renowned clinical, translational, and health services research, whose interests are in clinical, epidemiologic, and translational studies of sepsis, pneumonia, and multi-system organ failure, as well as health services research of the organization and delivery of critical care services. Dr. Angus is a leader in developing and evaluating approaches to facilitate smarter decision-making and faster learning in healthcare, including novel Bayesian adaptive platform trial designs, the application of machine learning to large-scale data, and the use of behavioral economics and decision psychology to support optimal decision-making. So with that, this is going to be a fantastic session. For those of you who has questions as the session goes through, feel free to pop it into the chat, and I'll be monitoring that. We'll have about 30 minutes from Siva, followed by 10-minute discussant from Derek, and then we'll move to questions and answers. So with that, I'll hand it over to you, Siva.
All right, awesome. Let me share my screen. All right. So I'll be presenting the Precise trial, Precision Resuscitation with Crystalloids and Sepsis on behalf of the Precise team. We have a big clinical team, a big technical team, so big thanks to everyone who's made this trial possible. I wanted to start with a clinical case. So Mr. Harris is a 52-year-old male with diabetes mellitus and hypertension. He presents to the emergency room with fever, cough, and shortness of breath for 3 days. His heart rate is 130, his respiratory rate is 32, and his blood pressure is 90/50. Mr. Harris is suspected of having sepsis from a bacterial pneumonia. He's given supplemental oxygen, he's given IV antibiotics, and he's also given one of the most common treatments given to patients in the hospital, intravenous fluids. In the emergency room, Mr. Harris receives 2 liters of IV fluids. His blood pressure is still low and he still looks sick, so he's sent to the ICU where he receives 2 additional liters of IV fluids. As he decompensates and he's being placed on life support, he gets another liter of IV fluids. I present this case not because it's unusual or unique, but to illustrate just how common of a treatment IV fluids are in the hospital. IV fluids are one of the most common treatments given, and every year, 30 million people receive IV fluids. So if you've gone to a hospital, you probably received some amount of IV fluids. When it comes to IV crystalloid fluids, there's 2 big choices. There's balanced crystalloids and there's normal saline. Now, when a treatment is this common like IV fluids, you would think we know which of these fluids is better than the other. But we actually don't know the answer to that. And after 13 randomized controlled trials and enrolling 35,000 patients, randomizing them to either balanced crystalloids or normal saline, we still don't have one fluid that's definitively better than the other. And that's probably because some patients do better with balanced crystalloids, some patients do better with normal saline, and when we group them all together in a clinical trial, we get a null result. So the question might not be which fluid is better, but the question might be which fluid is better for which patient. So using this precision medicine paradigm, we had developed an AI algorithm that identified a group of patients that had a 15% absolute reduction in mortality from balanced crystalloids compared to normal saline. So while for the average patient, it seems like it may not matter one way or the other which fluid is given, for this group of patients, it seems to make a huge difference. So for every 7 patients in this group that we could give balanced crystalloids to instead of normal saline, we could prevent a death. And so how do you identify this group of patients? Well, it doesn't take any esoteric biomarkers or any expensive testing, but we can identify these patients using universally available bedside vital signs: temperature, heart rate, respiratory rate, and blood pressure, things that are measured in every hospital around the world. And I've always been really interested in how can we use these measurements available in all settings, including low resource settings, to identify these groups that could be used to target therapies. So this is based on our work, development and validation of novel sepsis subphenotypes using trajectories of vital signs. So in the original work, what we did was we looked at retrospective data from Emory Hospital, and we looked at patients who were suspected of having infection when they presented to the hospital. We looked at their vital signs from the first 8 hours of hospitalization: temperature, heart rate, respiratory rate, and blood pressure. We applied time series clustering algorithms to identify distinct patterns of vital signs that patients followed. And we discovered that there was 4 patterns of vital signs that emerged. And we called patients that followed these patterns of vital signs group A, B, C, and D. So you can see visually what their vital sign trajectories look like in these different groups. And these groups had very different clinical characteristics and different outcomes. But again, our big question was, would they actually respond differently to different treatments? So the way we went about investigating that was we took an established randomized controlled trial from Vanderbilt, the SMART trial, which had cluster randomized patients to balanced crystalloids versus normal saline. And we went back and took that data and did a secondary analysis where we took the study patients and assigned them into one of our 4 groups based on their vital signs pre-randomization. So using their pre-randomization vital signs, we assigned them to one of the 4 groups. And although overall there was no mortality difference between balanced crystalloids and normal saline, our question was, would there be differences within our groups? And we found there was significant heterogeneity in treatment across these groups. And there was one group that stood out with a significant mortality benefit from balanced crystalloids, group D. So group D patients who were randomized to saline had a 35% mortality rate, compared to group D patients who were randomized to balanced crystalloids who had a 20% mortality rate. So this is where our 15% absolute reduction in mortality comes from. And this is the premise behind the PRECISE trial. Can we precisely target group D patients and get them the right type of fluids? So the PRECISE trial is a pragmatic, EHR integrated, single-blinded randomized controlled trial. It's EHR integrated, so the entire trial is happening in the background of the electronic health record. It's all happening in the background of Epic. So the vitals algorithm is running in the background of Epic, and the inclusion criteria are being evaluated in the background of Epic. And if a patient is group D and meets our inclusion criteria, and a clinician initiates a normal saline order in that patient, that's when randomization occurs to usual care or intervention. So again, randomization occurs at the point of the clinician initiating the normal saline order. So if a clinician initiates a normal saline order and the patient is randomized to usual care, nothing happens. The clinician gets no feedback from the algorithm. The patient will get normal saline, or at least the normal saline will be ordered will be signed and ordered. If the clinician orders normal saline and the patient's randomized to intervention, there's an EHR alert that tries to nudge the clinician to switch the order to balanced crystalloids instead. So I'm a clinician, and I'm completely aware that nobody likes EHR alerts. Nobody wants a BPA popping up telling them what to do. And so our whole goal in designing this alert was to make it minimally intrusive and maximally actionable. So the alert will only pop up when normal saline is ordered on a patient in the intervention arm. The alert pops up and announces that it's part of the PRECISE trial, announces that there's a potential mortality benefit if you switch the fluids, gives away my contact information as well, and then gives you the options of choosing the alternative fluid. So you choose the alternative balanced crystalloid, press accept alternative, and you're done. The clinician can also choose to stick with normal saline if they wish to. So you have the option right here, and then you'll have a drop-down menu where you just say clinician preference. And so it's the whole goal is to make it as minimally intrusive as possible. The other thing I want to point out is was a big point of discussion when we were actually designing this study. So the vital trajectory algorithm, the original version, takes 8 hours. So the question that Derek Angus brought up, Vinny Liu brought up, a lot of people brought up was, can you wait 8 hours to randomize a patient? And with the train have left the station by then, they would have already gotten some amount of IV fluids, and it might be the early fluids that actually make a big impact. If we go back to our clinical case of Mr. Harris, he's a fictional character, but he would have gotten most of the fluid in that first couple hours before hitting the 8-hour mark. So what we thought of was, what if we used a modified version of the algorithm where we see that these groups already diverge with the first set of vital signs. So instead of the trajectory model, we use the intercept model, which we've shown in our work to be 80 to 90% accurate in identifying group D patients. Would that be the better course? And that's what we ended up going with, to go with the modified algorithm, so that we would lose 10 to 20% accuracy, but we would gain that 8 hours of intervention, which might be where the actual real high impact could be. So what does the technical implementation of all this look like? Sorry, I hear some feedback. I think about it in 4 phases. So it took us 9 months to implement the whole study into Epic. And there's 4 phases. So the first phase was the algorithm implementation itself. So taking our algorithm, the code out of GitHub, and actually putting it into Epic to actually have it running in the background of Epic and being able to identify group D patients. The second phase was building out the inclusion criteria. So again, it's an EHR integrated trial. So there's no clinical coordinator on the ground enrolling patients or screening patients. Everything is automated within the electronic health record. So building out those rules within Epic itself. And then the randomization also happens within Epic. And then finally, building out the medication alert was the 4th phase. So those 4 phases, what it actually kind of the technical workflow looks like is this, and each of these phases are labeled. And I'm not showing this out here to explain each of these boxes because I don't know what a lot of these boxes are, but more importantly, to showcase the work that our technical team has done and the Emory Digital Office has done. And it's actually really impressive that the frontline technical team to watch them work through, and how do you piece together different functionalities from Epic to actually be able to do the thing we want to do with the trial itself. So the sample size that we're aiming to recruit is 2,002 patients, 1,001 in each arm, usual care and intervention. And we're expecting the time to enrollment to be about 12 months. The trial is happening across the entire Emory Healthcare system, all 6 Emory hospitals, including academic tertiary hospitals, hybrid academic community hospitals, as well as community hospitals. So we have diverse settings that we're running this trial at, while all settings also have Epic and are all integrated in that way. So the primary outcome that we're looking at is 30-day inpatient mortality. And the secondary outcomes are ICU admission, in-hospital mortality, receipt of vasoactive drugs, new renal replacement therapy, or mechanical ventilation. And of course, we have the process outcomes of how much fluid, what type of fluids did each arm receive as well. And I wanted to just talk about the analysis itself, which is an intention to treat analysis. And I think it's important to point this out because an intervention patient can receive 100% normal saline. You can imagine a clinician every clinician that sees this patient just rejects the alert and gives the patient normal saline. So so for us and the patient would still be classified under the intervention arm because it's an intention to treat analysis. So to really detect, to be able to have a chance to detect a 30-day mortality difference, we really have to separate these 2 groups. The proportion of fluids they need to be getting should be completely different. In order to do that, we need to really change clinician behavior in the intervention arm. To do that, we have to have a really effective alert. And so, from the get-go, we knew how important the alert effectiveness was going to be for the trial to show anything meaningful. And so we had this dedicated clinical education campaign that started 3 months before the trial started, which was run by our clinical education lead, Danny Mills. And it's still ongoing. But our goal was to reach all 6 hospitals, all 6 emergency departments, and meet with these departments individually, meet with each of the 17 ICUs individually, residency programs and fellowship programs that have trainees that rotate through any of these EDs and ICUs. And on top of that, we sent individual emails to every single emergency department and ICU provider, because our whole goal was any clinician who sees this alert has at least heard about the trial, at least peripherally by email that came across their desk before seeing this alert pop up. So what is the status of the PRECISE trial? So it started June 13th, so we're about 3 months into it tomorrow. We've randomized over 400 patients, and we have about a 70% alert compliance, which we're really proud of, because I think in the space of EHR alerts and BPAs, that's a fairly high benchmark, and I think a large part of that is due to the clinical education effort. But one of the things we're really interested in beyond the initial study itself is what are the factors that determine alert compliance when you're talking about these EHR alerts? What are the patient level factors, clinician level factors, hospital level factors that determine this? And what are tweaks you can make to actually increase the alert compliance? What is the ceiling of alert compliance? This might seem like a really silly example, but one thing that's obvious was obvious to us was, well, right now it takes 2 clicks to get through this. You have to click on an alternative, and then you have to click accept alternative. You can imagine if you had a default thing already selected, then it's a 1-click solution. And just moving from a 2-click solution to a 1-click solution could push that up to 75% compliance, 80% compliance. So there might be small tweaks. We couldn't do this because, surprisingly, the EHR didn't have that functionality yet to do that. But there might be small tweaks that we can make to incrementally increase the alert effectiveness as well. So I wanted to talk a bit about the lessons that were learned and kind of learning in the process of learning. So the PRECISE trial combines these 2 components of an AI algorithm trial as well as an EHR integrated trial. And these 2 things don't necessarily have to go hand in hand. You can have an AI algorithm trial that is not completely EHR integrated. You can have an EHR integrated trial that's testing something that's not an AI algorithm. But when these 2 things are present combined, there's some unique challenges as well. But one of the big lessons that we learned about AI algorithm implementation is that complexity equals less control over quality. And when I'm talking about complexity, I'm not actually talking about the functional form of the model, whether it's a tree-based model or a neural network, but I'm actually talking about the input space. So we had a very simple input space of 5 inputs: temperature, heart rate, respiratory rate, systolic and diastolic blood pressure. With just 5 inputs, I ended up having to do over 100 chart reviews just to figure out all the edge cases where things weren't mapped like they were supposed to be. And when you're thinking about an algorithm that has 100 inputs, that just means the threshold or the level of quality assurance would have to be much higher, and you might have to do chart reviews in the several hundreds or thousands to really think of all the different combinations that could go wrong. The second lesson is education is key, and it might seem like a truism, but what really was striking was clinicians who repeatedly rejected the alert. Oftentimes, these were clinicians who were not in any of the department or ICU meetings, and we didn't have their email for whatever reason, so they didn't get an individualized email, which kind of suggested to us that even something as simple as an email that just goes out that might, as long as it says your name and has a picture of the alert, that might at least prime you to be more likely to be compliant when you see the alert. The lessons that we've learned about EHR integrated trials. So again, one of the lessons is that the more complex the trial is, the less control you have over quality. And complexity here refers to the inclusion criteria. So we had a very minimal inclusion criteria, but even with the minimal set of inclusion criteria, we had to do lots of chart reviews to figure out the edge cases where patients would have been included, would have been flagged for inclusion when they shouldn't be, or would not have been flagged for inclusion when they should be. So when you abstract this to a trial with dozens of inclusion and exclusion criteria, that probably expands the number of chart reviews you'd have to do to really do the quality assurance for the trial. And there might be a level of complexity where it might not make sense to have an EHR integrated trial, and it might make more sense to have a coordinator on the ground to review these patients. The other lesson that we learned was that tracking systems are key. When we spent a lot of time with the technical implementation, and in those 9 months, very little time was spent thinking about tracking systems, which once the trial started, we realized how essential it was. The whole thing with EHR integrated trials is once it's on, it's on. It's just running in the background, enrolling patients, randomizing patients. So before you start something like that, you want really good tracking systems in place to make sure you're monitoring and documenting and keeping track of all these patients that are just being enrolled in the background of Epic or whichever EHR system. And so now we've, have a tracking system for every medication alert that fires, silent BPAs for control patients, and a tracking system that just records every patient who meets inclusion criteria, whether or not they ended up getting randomized. So I wanted to spend just a little bit of time talking about sepsis subtypes. So this is a trial of a sepsis subtype, and sepsis is a dysregulated response to infection that results in organ dysfunction, a severe infection, and it's a very heterogeneously defined syndrome. It's a nebulous syndrome, and because of that, over the past half a decade or so, there's been this huge effort to split up this heterogeneous syndrome of sepsis into sepsis subtypes, whether it's called sepsis subgroups, phenotypes, subphenotypes. There are subtypes of sepsis that might help with the precision medicine approach. And it seems like every research lab has their own version of a sepsis subtype, present company included. There's so many ways to do this. And there's so many different data elements to choose from and so many ways to split up sepsis. You can use vitals, labs, comorbidities, demographics. You can use biomarkers, transcriptomics. So there's thousands of potential data elements and combinations of data elements to choose from. And the crazy thing about this endeavor is even if you choose the same set of data elements, if you use two different clustering algorithms, you might end up with two different sets of sepsis subtypes. And there's hundreds of clustering algorithms to choose from. So you have the situation where you have thousands of data elements to choose from, hundreds of clustering algorithms to choose from. And so you have this whole universe of potential sepsis subtypes that are out there. So, when I was starting this research, there was this existential moment where I was like, so then what's the point? Which is the good one, or which is the right one, and which is the best one? And it turns out there probably is no right way to split sepsis, and there's no best way to split sepsis. And it reminded me of this quote that's famous in the data science world: "All models are wrong, but some models are useful." And all sepsis subtype models are wrong because you're artificially splitting up an already artificially defined syndrome into these subgroups. But the question is not whether it's right or wrong or the best model. The question is, are these models useful? And for a model to be useful, the sepsis subtype has to inform clinician behavior in a way that changes the clinician behavior in a way that actually improves patient outcomes. And I think that's the real the strength of the Aim High initiative is asking us to step back and ask the question of, are the models useful? So just abstracting away from just sepsis subtypes, are AI models useful? And to answer this question, I think the AI model would have to change clinician behavior in a significant way, enough way from the default behavior to actually improve patient outcomes. And I think that's really the question we're going to be asking going into the future in the space of AI in healthcare is, are our models useful, and what is the best way to actually test that? So again, big thank you to the entire Precise team, and thank you for Aim High and the Health AI partnership for giving me this opportunity to present.
Thank you, Siva. That was phenomenal. And you identified, I think, a lot of really important issues, which we'll dive into. So with that, I'll turn it over to Derek.
So first of all, so thank you, Siva. I think it's really great that this trial is in the AIM-HI program, for a whole bunch of reasons, not the least of which because it's such an exemplar of many of these sort of inherent challenges that we have in sepsis, in, as you alluded to, sort of embedded EHR trials, and then also obviously about trying to work out when some sort of AI-based information management system can or cannot improve care. There's a lot of different directions that we could go here in the conversation, and I guess the point of the discussant is maybe to just sort of throw out a few themes and provide maybe a little bit of context, and then sort of open it up for people to sort of take us where we want to go. So maybe I'll start. I have a few notes that I took as you were speaking, and I might start with a couple of things, since not everyone here spends all day long thinking about sepsis. Maybe I'll just talk, you know, and more power to you for not doing that. Maybe I'll just talk a little bit about my thoughts on why you're doing this study. So as you alluded to, IV fluids are given all the time. And we have, I think the first day I thought I was going to go into intensive care, which was back in the 1980s, the first research conference I ever went to was on what intravenous fluid should we give our ICU patients. And here we are sort of 40 or 50 years later, and we still don't know. It's a bit depressing. You have, just so that everyone understands, you're focusing just within the choice of crystalloid, and you're focusing on this notion of whether the crystalloids should be so-called balanced or not. And that's because there's a concern that traditional unbalanced crystalloids have too much chloride in them. And that doesn't matter in the short term, but maybe if you're giving people a lot of fluids, you're essentially going to induce chloride toxicity. And there's definitely good experimental evidence that that can be harmful, but there's still a lot of debate in the literature about whether it really makes a difference. And if it does make a difference, people think it might only make a difference in the subset of patients that end up getting a lot of fluid. And so that already casts something up here, which is the model predicting patients that would benefit or not from one choice of fluid condition upon whether they end up getting a lot of fluids. Like if you manage them with not too much fluid, then maybe it won't really matter. But there's no question that our entire field of sort of all of critical care and all of emergency medicine, we can't get out of our own way around the choice of fluids. And so you wading in here and trying to work out, is it because we can't understand which patients should get the fluid is definitely an on-point question. And so then the next thing is you're getting to this notion of phenotypes, and I would point out to the group, in a way, what we're talking about here are cryptic phenotypes. If it were clinically obvious, you wouldn't necessarily need the algorithm. You're using some unusual combination of data that are presumably opaque to the clinician. And we don't know how opaque, but you're presuming that there's some way that the clinician wouldn't have known, but you're going to sort of massage the data and then come up with something that might not have been clinically intuitive. And that's the thing that you're then trying to put in front of the physician. And that raises a bunch of issues, including whether the clinicians would then learn over time and begin to guess, and whether that would then maybe even change what's happening in the control arm. But you spend a nice amount of time talking about, given that we are coming up with this potentially cryptic phenotype and then trying to alert people, how can we make this actionable? And you also pointed out that it has to be actionable really quickly. And so a lot of the application of EHR embedded trials, some of the big Duke trials like Adaptable, et cetera, there can be an outpatient setting. There can be a couple of weeks to get this decision right. In cancer, you've got maybe a couple of weeks to run on the tumor histology before you make a decision. Here, this has to happen immediately. And so that's, and there's lots of clinical conditions where we want to immediately get the information in front, so-called live edge. So this is an impressive exemplar for that. Assuming that these phenotypes are important and that you've now managed to get them in front of people and that you're now nudging people with reasonably high compliance, then you need to know how it would make a difference. And so you're doing this trial. The trial is a trial of getting the prompt. And as you said, you've got 70% compliance, but that's presumably not random compliance. And so it'll be some of it will be random, some of it will just be the particular physician that doesn't like it. But it does raise the issue of whether all the action is in the 30%, and if so, that could threaten the experiment. And then, of course, you're running it in Emory, but even if you've made all due attention to the internal fidelity of the trial, there are going to be important questions, I think, about generalizability. And some of the things that will come up will be generalizability, not only about whether the phenotypes would be finding the same kinds of patients in other settings, depending on differences in case mix, differences in the way in which data are collected in different healthcare systems, but also the generalizability of the attitudes of the physicians, especially since this is a nudge, and whether the folks at Emory all know you guys are great and are very happy to follow your advice, but maybe they won't do it elsewhere. So it's interesting to think about generalizability, not only of the patients, but also of the target here, which is sort of the physician cognotypes. I also thought, you ended talking about phenotypes, and the application of AI here is essentially these machine learning models on treatment response. And so there's a lot of action in this field in so-called heterogeneity of treatment effect. And many would argue that phenotypes, where you're dividing the group into, say, 2 or 3 groups, is not very sophisticated HTE. HTE ultimately would be individual treatment effects. And even within a phenotype, even within the 1/3 that you think might benefit versus say that, let's say it's a third for benefit, almost no effect, and maybe harm. There could still be significant variation within that phenotype. The very first description of HTE in sort of modern clinical medicine was that review of the carotid endarterectomy surgery back in the 1990s, where all the patients had the same phenotype. And yet the treatment effect ranged from harm to effect. And so even within those sub-phenotypes, there could still be large variation. And that then speaks to you've paused the learning of the AI prior to the beginning of this SAMD effectively. But obviously you're accruing data, and in an interesting way, you're accruing data about physician override as well, which may contain information. So one interesting thing to think about is after the trial is done, would you actually be able to make even smarter decisions from the analysis of the trial for a smarter algorithm in the future? The last thing I'll close with is you get intravenous fluids all the way through the hospitalization, and presumably the benefit or the harm is really related to the sort of the aggregate fluid load. And I didn't hear you. I really love that you tried to get in front of the physicians before they were hanging any fluid, or as early in their IV fluid treatment decisions algorithms as possible. But let's say you've successfully converted the emergency medicine physicians to all faithfully follow the algorithm when they're randomized to the algorithm. What then happens when they go to the ICU, and how can you maintain the fidelity? And do you keep on telling everyone this patient was randomized to the intervention? The intervention said, please give balanced crystalloid, so don't dare give even 200 cc's of normal saline. I don't know how you're maintaining the fidelity throughout the hospitalization. All right, I've chattered on for probably my 10 minutes. So I've just tried to respond to some of the clinical content issues and some of the trial design issues. And some of this notion of sort of phenotyping, I don't know whether it makes sense or not, but these are some of the things going through my mind. I wonder whether you want to respond to them, Siva, and then whether that stimulates other people to ask much smarter questions. Was this what you wanted,
Yeah.
Vinny? What you wanted?
No, that was great. I'm giving Siva a chance to think these through because
Yeah.
there's across many domains, many interesting concepts. But Siva, maybe you can kind of flesh out some of your thoughts. We went all the way from the history of fluids through all the way up to the fidelity to the intervention, one which is chosen many times over days, presumably, and anything in between. Maybe just some fleshing out of how you guys thought about this project and the targets you're choosing.
Yeah. So I'll start with the easiest question, which is just how the trial design itself. So the question of, initially, I think the emergency room gets the alert when the patient is first randomized. But once they're randomized into the intervention, anytime normal saline is ordered, as long as it's in the ED or the ICU, the clinician will get the alert. So, so it kind of increases the complexity because, to have a perfect patient for every clinician along the line who ordered fluids over that 30-day study period, up to 30 days in the ICU would have to have would have to choose, would have to accept the alert. So each looks like you had a question there.
So what does the 70% compliance, is that just a calculation of the total number of instances of ordering the fluids, or is
Exactly.
that 70% of the 200 patients out of the 400 that have been random?
No, it's 70% of the alerts that were fired had a compliant result. So it's a slightly, we haven't really, we haven't had the DSMB's meeting next week. We haven't had any further kind of analyses into the actual what
How many
percentage of
patients actually
yeah.
got
Yeah, we have
guideline concordant care all the way
exactly.
through?
We have an estimate of percent of normal saline, average percent of normal saline the patient gets over the study period in usual care versus intervention. And it's fairly well separated. It's I think it's 70% versus 30%, something like that, 30% normal saline in the intervention arm. And of course, that varies per hospital. And so this really tests the entire pathway where it's not truly testing whether group D patients benefit from balanced crystalloids. It's testing whether, if you believe that group D patients are benefiting from balanced crystalloids based on the secondary analysis that we did, and the alert pops up, whether that alert changes default clinician behavior enough. So there's three components that I kind of think of. There's the default baseline clinician behavior of the ordering pattern. So if the baseline ordering pattern was 0% normal saline or very little normal saline, where it might be in some medical centers, that would be difficult to conduct the trial there because you're not going to change anything because it's already changed to balanced crystalloids for everyone. And then the second part is how much do you change that with the alert? And then the third part is, now that you've changed it with that alert, is that adequate enough to reveal the same mortality benefit that we saw from a secondary analysis of a randomized controlled trial?
Can I just, for the sake of, again, for people who are not sepsis researchers, it would be quite costly to have a default be to always give balanced crystalloids. They're inexpensive, but they're still almost logarithmically more expensive than salt water. Normal saline is really cheap. So I think we do want to give normal saline all the time, except when we shouldn't, if that makes sense, which is what you're targeting. So I think, this notion of, well, does it all become irrelevant if we just ask everyone to give balanced crystalloid all the time? That would be an expensive move to just start giving it all. So I think you're right to try to only tell people to not give normal saline when you think it'll be harmful.
And then a couple of really interesting things that were brought up. This is, again, just for everyone, this is a very specific question of what type of crystalloids to give. And I think in sepsis, the big kind of fluid questions, there's lots of fluid questions, but there's a bigger debate of crystalloids versus colloids, and when you give one versus the other. There's a question of how much fluids to give in general, restrictive or liberal. And so this kind of answers a very niche question within the larger fluid debates in sepsis and critical care.
Yeah.
And then the one
Go
other
ahead,
thing I wanted
Siva.
to also highlight was the phenotypes. Distinguishing that these are not clinical phenotypes, so it's not something that's recognizable necessarily at the bedside. But also balancing that with it is only 5 vital signs, so it's not too unrecognizable. They're we kind of describe Group D as in general terms hypotension without SIRS. Group A is probably hypotension with SIRS, and that's probably one way to kind of categorize them. But of course, since it actually uses a Euclidean distance metric, it might not be like exactly in line with the clinicians get. But I think they're clinically opaque, but clinically maybe a little more understandable than phenotypes that can get really complex.
Do you see that as a blessing and a curse? Like, if it's easy to describe it, it might make the alert more acceptable, but it also might mean that in the control arm, people might just say, "Oh, I see that patient." So that's the patient that had they been randomized to the other arm, it would have told me to give balanced crystalloid. So I'm just going to go ahead and give balanced crystalloid, and then you ruin your experiment.
I think honestly, outside of our immediate group, I don't think anyone I think most clinicians who are receiving this alert kind of they've heard about it, so they'll accept it if they think it's a reasonable thing to do. But outside of the immediate group, I don't know that too many people have really tried to guess which one is which. But I think if it was widely adopted, it could be something that's can change, could be something that's clinically, I guess, estimatable. But I don't think it would necessarily change ordering practices within the trial itself. One interesting thing that that you brought up was clinicians changing behavior over the trial. One thing we've considered is they might do that just because they don't want to receive alerts. So if you kind of have this alert that randomly pops up once in a while when you order normal saline, you could imagine a clinician being like, I'm just going to do balanced crystalloids. I just don't want to deal with this extra step. So that's another thing. We are considering the temporal component in our analyses and whether that kind of changes the ordering patterns too.
I'm looking in the chat. We may have answered this question, but Tommy says, can you provide some insight into why a clinician in the ICU would choose the balanced crystalloid fluid? Is it that of the many existing RCTs? There are pockets of evidence of when to use and not use it. I think just to give some background on the rationale behind kind of, why they would choose it in the first place.
I think it might be better coming from Derek Angus himself. What is the what is the reason to choose one versus the other?
Oh, so I think so. Some of the original studies that suggested harm with normal saline had this compelling story that fluoride was toxic, and then when you take some of the trials, like the BASICS trial, the huge Brazilian trial that didn't show a difference, then some people end up saying, well, the only reason it didn't show a difference is because too many patients in that trial didn't get enough fluid in either arm. And so then you get sort of clinicians who end up thinking, I don't think it's too expensive, and I like the rationale of protecting my patient from chloride toxicity. Plus, intensivists are an ornery bunch who are often they like to do things that they feel make sense physiologically. They have a mental model of the mechanism of action. So if they were convinced by the theoretical risks of chloride toxicity, and they might say, well, this particular patient would be getting a ton of crystalloid, and I'm very nervous about poisoning them with saline. So it's that kind of story. Could you detect any sense of pejorative overlay from me?
No, that was absolutely objective. One thing that stood out to me, Siva, was this concept of tracking, right? Because obviously there is a lot of tracking that happens in a traditional trial, whether, it's EHR or not, but then this is kind of at the interface between, it's embedded, it's kind of working behind the scenes, and there's multiple areas, like you in your last slide or in one of the later slides, you kind of the concept of the algorithm itself, the fidelity into the EHR embedded aspect, and then the ripple effects, not only in your target population, but in the other adjacent patients, right? Like the concept that someone just doesn't want to get any more alerts. I don't care if they're D or not. Every time I see a patient, oh, they told me this is probably better, I'm just going to click there. And so you may be observing not only a diminishing cohort for randomization, within the group D, but that is probably a signal that you're seeing practice change for all sepsis patients. Do you know what I mean? Because they may not have the data to approximate who a D is. And so they're just kind of blanket applying this across all the patients who seem like they fit the similar criteria. I wonder if you've thought about that at all. And I mean, there's learnings to be had. I like to think of this like when you turn that giant ship, there's lots of waves of data. And some of those are what's happening in the adjacent patients that someone who doesn't have the insight of the AI algorithm can't observe, but then kind of applies to another patient population, whether you're tracking to that extent or how you thought about that.
Yeah, so one of our co-investigators is actually proposing a study where we look at normal saline patterns. So normal saline and balanced crystalloid patterns have been changing just because of the SMART trial and basics, and things have started to shift just over the past couple of years. But with our clinical education itself, like the 3 months preceding the trial, did that start to change people's behavior just because like, okay, I don't want to deal with this alert if it does start coming. And then once the trial started, we're going to be tracking study and non-study patients to see just fluid prescription patterns and what happened over the course of the study. In the 3 months so far, we haven't seen a drop in enrollment, which is that's true that that might be like the first kind of like sign that people are still like, ordering less normal saline since the randomization is conditioned on initiating a normal saline order. But yeah, we're definitely interested in looking at that.
Siva, you alluded to this notion of the strength of the nudge and how much you could play with the choice architecture. And for example, you could just sort of default rather than, and have fewer clicks, sort of grease the skid, so to speak. And you also alluded to the fact that there were some sort of pragmatic limitations on how much you could do, like that would be a new build, and putting aside the pragmatic and maybe putting on two hats, your theoretical hat about trial design, and then also your hat about sort of ethics. What if you had complete control, would you like to have had a very strong nudge? And is that appropriate? And in sort of learning health system embedded research, sometimes people will do cluster designs like Vanderbilt. Typically will in fact, you drove this whole thing from the SMART trial, and obviously like we've got Peter from Vandy. So they worked hard to try to make sure that they had as much compliance as possible, even though there was waiver of patient consent. There have been discussions about whether the clinicians themselves should be consented maybe at the start of the whole thing, and there's pros and cons and all of that. But could you just tell us your thinking on, if I had complete control, I think the right thing here would have been to have had a very strong nudge to get very high compliance, so that at the end of this experiment, we wouldn't be trying to do all sorts of weird post hoc moderating and mediating analyses to try to understand what it means, because the intention to treat looks very different from the number of people that got it. And what would be the ethical consequences of a very strong nudge?
Yeah, so initially when I think I started with how this should be designed, I actually did have a very strong opt-out nudge in mind, where it would switch the fluid, but the clinician can like go back and second to like ignoring the logistics of whether it's possible and epic, but it would automatically switch and tell the clinician to switch, but they can go back. So then the clinician would really have to believe in the normal saline to go back. As far as like whether like what is the ethics of that, we could really base even the waiver of consent consideration framed it around the SMART trial and the equipoise that remains around normal saline versus balanced crystalloids. The both are part of routine clinical practice. The crystalloids in general are only given when the clinician initiates the order and the clinician gets the final say. So ethically, even an opt-out, I personally would feel that the clinician would still have like they would have to have a much stronger reason and rationale to go back and order normal saline, but they would still have that final decision in their court. So I think I personally wanted an opt-out version just to truly separate it to more clearly answer the question. But the other consideration here is also, I guess it kind of gets into the logistical, and it gets into your generalizability question. At that point, are we so heavy-handed that this is not a generalizable thing? And sure, you convinced Emory to opt out or like do an opt-out method, but is that really realistic across like other healthcare systems?
So I see Peter raise his hand, but that last point, one way of thinking about that is when you're doing the proof of principle, it's almost like the phase 2 of the efficacy trial. You want such a clear signal. You don't want to kill the project because you didn't have a strong enough nudge. And so maybe you do a really strong nudge, get very high fidelity in the two arms, clear separation. And then if it turns out it makes a difference, then later studies can evaluate as you soften the nudge, as you go from efficacy to effectiveness, how much can it soften, etc. But
Interesting.
Anyway.
Yeah,
Peter.
thank you. I was just going to jump in with a comment and a question. Great discussion. And I have to admit, I was not directly involved with the study here, so I'm very aware of it because of my colleagues' work. But I want to mention that my understanding is that as we were doing some similar kinds of pragmatic approaches here, there was something to your point about education, but also just kind of cultural acceptance, where the design and the way that it was implemented really led to people started to, I think there was a version of the study that was different than this one that was about antibiotic comparison that they called ACORN. And so you all may be familiar with the ACORN study. And people would just talk about it as, oh, we're acorning the patient. I mean, it came to a point of just saying, and basically what that meant was we're going to click this button and they're going to be randomized to one arm or the other. And that was just the default, right? So I wonder, as you've been thinking about this, whether, to that last question about nudges or just making things kind of by default sort of doing the right thing, assuming there's equipoise, whether that's something that you're learning about and might lead to some changes we would consider and then want to study further.
Yeah, so you mean like as that culturally, like if everyone kind of accepts that this is part of this learning healthcare system?
Yeah, I guess as opposed, let me be more clear. I guess as opposed to sort of you either opt into this approach or you opt out of it, just kind of making it a default activity, which is you just sort of choose one arm or the other as part of the order set activity, if you will, right? So it isn't really about per se opting out unless there's some reason they shouldn't be on, those fluids, either one of those, right?
Yeah, I mean, I definitely think that's like that would be the vision of like getting buy-in for something like that as like just a usual part. And I think that if there's a next trial after this, I think that's where we can maybe like push and see what is the limits of like, if there is clinical equipoise in the situation, how strong-handed can we be with this nudge? And again, like Derek was saying, that way we kind of prove the concept and then afterwards can worry about like whether this strong nudge would apply in another healthcare setting or not.
Makes sense.
So we just have, thank you, Peter. We just have a couple more minutes. So I'm going to end with a question to Siva and Derek. So let's do a pre-mortem here. Negative trial. What was the reason for it? Siva?
Negative trial. I personally think the reason is we've already switched to heavy use of balanced crystalloids across Emory. This is not as true in the community hospitals in Emory Healthcare, but definitely in the main academic tertiary hospitals, the two hospitals, there's such a heavy use of balanced crystalloids as baseline that it's harder, even if you have 100% alert compliance. It's not, you're really comparing proportions that are not as well separated. So I think that would be my guess as to the pre-mortem of why this trial did not show a mortality benefit.
Okay. Derek, you have the final word.
I'm thinking multifactorial. I'm thinking it probably is what Siva just said, but I would say that that's in both directions. The control arm drifting towards the middle, and because you don't get enough fidelity in the intervention arm, it's not as separated. So both arms are moving to the middle, together with this notion that that true harm signal, had you given saline, may only it may not be as large in the replication set as it was in the original development set, and it may be very contingent on getting a big load of normal saline, which a lot of the time people just won't get. So
great. Well, we are really excited to see how this goes, and there's a lot to learn both from the trial itself as well as the adjacent aspects. So thank you, Siva. Thank you, Derek. Thank you to everyone who attended, and please follow the link and sign up for our session in October. Thanks, everyone.
Thanks.